Welcome back to the second part of our NHS West Yorkshire board meeting, and we're here in Leeds today. We have just concluded a discussion on primary care, building on our discussion from a year ago and moving on plans together into next year. And thank you to everyone around the table for their contributions today. We now move on to item 7, which is my chair's report. As you know, colleagues, this report provides an update on governance arrangements, work we're doing with stakeholders and across our partnership. Some points I wanted to highlight, and particularly to get into the minutes today. One is the appendix in the report, which is about a refresh of board roles and remits, and that is around testing the workload and those roles and playing to people's expertise around this board table. So you've got the information there, and that's out there in the public domain, also aligning with the Fit and Proper Persons framework from NHS England. We also continue with our visits programme at board level, continuously learning from that. And our most recent board visit was to Yorkshire Ambulance Service at the end of last month. And thanks again to the senior colleagues there and to the 111 call centre who hosted us that day, which was a great visit. And it combined well with an ICB, Integrated Care Board exchange we held with Kent and Medway system and leaders from there that day, which was a really welcomed opportunity. And the last thing I wanted to mention was around, 2 points. One is that we have a working group established of trust provider chairs and also company secretaries in the NHS looking at chair and non-executive development. First of all, looking at that on NHS boards. Fit and Proper Persons framework is a point of reference for us, but it's very much linking to one of our strategic ambitions around greater diversity in health and care leadership. And we also want to have a broader remit on looking at board roles across our system in health and care, and that includes the voluntary and community sector. And we had our first meeting last week. And my last point is to thank the chair of LACALA, Diane, who is retiring and moving on next month, and welcome Colin, who'll be the new chair of LACALA coming into the system, who's already very actively involved, including helping us with new chair and non-exec development in the system. So that's my report there. It's very much aims to align with the CQC, Care Quality Commission well-led framework, Fit and Proper Persons, as well as giving some governance and partnership updates. I don't know if anyone has any questions at all about the report. Rob.
I just wanted to clarify whether this is Harris's last meeting as well. No. It's not good. I've been misinformed then. Okay.
Thank you. So we will note that Harris has been with us on a non-executive director placement through the NHS England Next Director programme, and we'll be concluding that in the coming weeks or so. So Harris, thank you for your contributions, including today already. And I know that you've got a lot out of the placement as well as us. And we'll be sharing the learning from that, both Harris sharing his direct learning and experience on our own to one of our future remuneration and nomination committees, which Majid, as our non-exec chair of that, will be helping us to prepare for. But yeah, thank you, Harris, for your contributions today and over the last few months or so, and particularly for us as a new board. Okay, Rob, I'm going to hand over to you. Oh, sorry, Brendan. Thank you.
Sorry, Kathy, just one question. It was the under the workload, I can understand why things have been distributed. It was the final column about the provider collaborative supporting role. What is that?
So that is more of an opportunity for NHS West Yorkshire non-exec members to have an opportunity to learn more about how provider collaboratives work. So it's not a formal governance arrangement, but it is also particularly to give someone on the non-executive team a greater insight into the work. So I hope that it'll be possible for non-exec members to observe at least one of those meetings every year. I know for Wyatt and for mental health, learning disability and autism, as well as the community provider collaborative, you have regular meetings, and I hope that non-exec members could come along to those.
It's not something I'm aware of.
Okay.
Perhaps we could have a conversation.
Yes, of course. Thanks, Brendan. Jane.
Yes, thanks, Kathy. Jane Madeley, non-exec member. I just was interested in paragraph 5.4, the exchange with Kent and Medway, ICB, and you talked about useful insights between the organisations. I just wondered if there were any headlines from that that it was felt it would be worth sharing.
In some ways, so it was a private exchange, so it was Chatham House rules, which is always quite nice in terms of leadership exchanges. There's something particularly Sadie Frederick, the chair of the ICB at Kenton Medway, and I've been working on an exchanging practice for a number of months now, which is about how you embed local people's voices into decision making. And he very much wants to learn from us on how we run engagement sessions, and we want to learn from him. They ran a very successful AGM in Kenton Medway, including having a health check bus there on the day, which attracted quite a lot of people to come along to the AGM, come and get their health check, as well as come and learn more about the work of the local NHS Kenton Medway. But it's really helpful to have these sort of informal exchanges with not much of an agenda. It worked very well that day. Thanks, Jane. You want to?
Yeah, I think it's... too many lights on.
Jane, is yours off? It is Laura.
No, it's on it's a control one. That's why it's always on.
Yours
is on.
It's not going off. Colleagues, sorry about this. We have a number of microphones that are not turning off and on.
Everybody should check theirs and see if it's his mic off.
Rob, do you want to carry on?
It's weird. Well, is yours working, Kathy?
Yeah.
This one is. So, Rob, if you want to finish up on that point.
Great. So just to say, it was helpful, I think, to discuss with Kenton Medway the way we approach things and to pick up some tips from them. They've offered a reciprocal visit, so we'll take that up. It's also helpful to get someone to hold the mirror back up so you don't take for granted some of the things that are good, like having strong provider collaboratives that work together on issues for the system, like the way we differentially consider issues sometimes depending upon the different contexts. So the different management cost reductions in different places, for example, that we've done, or the differential dispersal of Core 20+5 funds based on inequalities and deprivation. So all of those things they thought were really positive and things that we probably might take for granted if we're not careful. So it's always useful to have that mirror held up to you.
Thank you, Rob. I'm just going to pause the meeting just to check with our AV colleagues that our microphones are working. Thank you very much. We just had a technical pause there, and then we are back with our meeting here in Leeds for NHS West Yorkshire Board. We're now going to move on to item 8, our Chief Exec's report, and I'm going to hand over to Rob Webster.
Okay, thanks, Chair. So, in the interest of time, I'll take the report as ready, but there are some updates. The Secretary of State for Health and Care has changed since this report was written. So it's Victoria Atkins MP and the ministerial team too. So for those of you who want to know more about that and their different portfolios, we can share a briefing around, or you can access the NHS Confederation or NHS providers briefings online. We've also had confirmed the additional resources that were outlined in the note that we expected to come into West Yorkshire, and we'll pick that up later on under the finance report and in the private part of the meeting when it comes to the detail, so that we can sign off where we think we are with that additional resource and the potential consequences of it. Just want to say thank you to everybody who's been involved subsequent to that and money being announced. At the same time as we're going through the last couple of weeks of the consultation on our operating model, the same staff and the same partners have been going through a refresh of the plans, given that we've had additional resources and some additional requests from NHS England to consider. And that's required us to do a huge amount of work. And again, that's built on the really good engagement and ownership of the agenda between all partners in all of the places. Our finance forum working together to make sure that we all considered, understood and agreed any plans that may be presented to us. And also the work of NHS England colleagues and others to help provide some support and clarify some of the questions that we had. So those additional resources are very welcome. Don't know what will happen tomorrow in the autumn statement. and we'll wait to see what happens in that. If there are additional resources for local government, which will be very welcome, or for capital and estates in the NHS, those will be very welcome, but we'll wait and see. And in terms of the consultation process around the operating model, we've concluded that, again, a huge amount of work gone on around voluntary redundancy, around new structures, engagement with every member of staff in the system, ongoing communications, etc. I don't know, Kate, if there's anything that you wanted to add in terms of partnerships with staff side or anything else on the operating model the board needs to be aware of.
No, thanks, Rob. I think just to thank everybody who's been heavily involved. I mean, my colleagues who were here from the EMT, when, as you said, they've had lots of other things, that the engagement levels, I think, have been significant. I think it'd be important to thank our union and staff side colleagues. I meet with them every week during the consultation period, and I think they've been really instrumental in sharing with us concerns, ideas, feedback from colleagues right across the ICB. So where we have made some changes, I'm sure, to structures, I think some of that has been very much because of that engagement with colleagues. We are now very clearly at the stage where we've set out a very comprehensive timescale for the next stages, which all of our staff have received. So we close on Friday, and then the final structures we plan to confirm on the 11th of December. So thank you.
Thanks. And I guess the only other thing I would say is that it's genuinely welcome that we focused a lot amongst ourselves across the last 6-7 years around how we work together, what we believe in, and how we continue to deal with the things that are thrown at us in this difficult context. Because that allows us to have the conversations about what's the right thing to do around the money, around what we prioritise in terms of the work, how we respond to some of the broader context when it comes to tensions in communities brought about by conflict elsewhere in the world, and also when it comes to us considering how we start to approach next year and beyond. You should see from the Care Quality Commission's report into the state of care, they reference the fact that the factors that affect people's care, their access to care and demand, go beyond the NHS. And they talk about the cost of living crisis, they talk about staffing and the impact upon staffing and their mental well-being. And I would hope you recognise that our partnership has focused on the cost of living crisis. Our partnership has focused on the wider determinants. Our partnership has been looking at compassionate leadership, health and well-being hubs for staff, and making sure that we focus on the things that matter. So I'm happy to commend the report to the board for context, for the board to note the points in the covering paper and to answer any questions.
Thank you, Rob. And we note the appendices that come with that as well, both letters that have gone out from from the ICB or the Health and Care Partnership across to our partnership and our colleagues within the ICB, as well as the letter also that came from NHS England on the 8th of November with a message around systems living within their baseline system allocation, which we note. So I've got AC, then Fatima, then Harris. Does anyone else want to comment at all on this report? No, or ask any questions? AC first, and then we'll go to Fatima.
Thanks, Kathy. Thanks, Rob. Very comprehensive report. Thank you, Arunanshu Chatterjee, Non-Exec Director. My question was linked to the Community Diagnostic Centres, CDCs. As two sets of questions and an observation. So the first one is the original aim of the CDCs were to try and I'm reading verbatim, to deliver additional diagnostic capacity in England by providing quicker and more convenient access to patients, reducing waiting times around hospitals or even closer to their home. So one of the Wakefield one is in a very public place. Two of them are planned to be around hospitals. I don't know if Leeds and Bradford, they are linked to hospitals or they are in community settings. While there will be sort of operational challenges around that in terms of trying to provide that, it was sort of intrinsically linked to inequalities and better access to those very communities, which possibly find sort of it challenging reaching those diagnostic centers. So while we'll definitely deliver an overall sort of capacity improvement in this particular space, what are the plans to evaluate this over the next 3 years in what it delivers effectively across those themes in improving capacity? But more importantly, what we had extensive discussions around primary care, early identification within deprived neighborhoods, and access to diagnostic capacity around that particular space. And the observation being is that the program is delivered before time, as I read it, and the government is saying that it'll deliver all the CDCs by spring next year. If that happens, I think that's one to celebrate in terms of at least, and then communicate to the wider audience that we have added capacity and the plans in West Yorkshire. At least that is a positive message to be put out.
Okay, so I'll bring in various people around the table to talk about their community diagnostic centres and some of the innovative approaches that we're taking. So in terms of the access to diagnostics, if you look at the performance report later on, you can see that we've been doing pretty well. Things are fairly challenging when it comes to reducing waits for diagnostics. And to the point that was raised earlier by Becky, we need to make sure that people are receiving the appropriate diagnostics at the appropriate time for the appropriate issue. So having CDCs linked into places and into acute settings and managed in that way is a very positive step. In each of the developments that we've taken forward so far, there have been a range of assessment criteria which have required us to achieve if we're going to get the funding, including issues like date of completion, throughput, connection to services. And I think your prompt, AC, around inequalities reminds me that we still need, within the Finance Investment Performance Committee and our place committees, to do more work to disaggregate the indicators by deprivation and other measures of inequality. So I don't know if various people around the table want to talk about how that's been taken into account in their CDCs. So Brendan's got Huddersfield and Halifax, and Karen's one of the partners in the Huddersfield CDC. But Brendan, I don't know if you want to add something.
AC, I think the two that were near the hospitals, were they the Halifax and Huddersfield ones? So I think the Halifax one is in the city centre. The Broad Street is where our community services have a base, but it's actually it's opposite the bus station in Halifax. And the Huddersfield place will be in a purpose-built university building that it's not as near to the city centre as town centre as we would hope, but it is there and it's separate to the acute trust. What we would hope is that we could put other services in there as well. It isn't just about the diagnostic services. How do we liaise with our community and mental health colleagues to put different services in there to do what Rob's described? How do we make best use of the space? There's a different way of doing this, which we're not waiting for guidance necessarily on. I think we need to forge ahead and plough our foray.
Thank you, Brendan. And then Karen, do you want to come in from Community Services? And Mel, welcome from Bradford District and Craven.
Yeah,
Karen.
Just to say on the back of what Brendan said there, the CDC is on the university site, and in another one of those new buildings there are community services embedded in that offer. So we are trying to bring things together to offer a coherent whole to people in a different way.
Thank you. It's really helpful to hear this in practice. And Mel?
Yes, again in Bradford, for Bradford District and Craven, ours is located, it's called Eccles Hill Hospital. It's not a hospital in the traditional sense, it doesn't have inpatient facilities. It's a partnership of independent providers and some services provided by the hospital. It's about 6 or 7 miles away from Bradford Infirmary and on the edge of one of our largest housing estates of IMD 102.
Thank you, that's really helpful. James, do you want to come in, and then we'll go over to Fatima and then Harris?
Yeah, it's just really, I suppose, in terms of linkage there and with the inequalities, I suppose I wanted to also mention about long health checks and the fact that that's linked with the core 20+5. It's looking at the most deprived areas there, and that's linked in with the diagnostics. So I suppose it's kind of bringing in other aspects that will be linked in with the inequalities that links in with diagnostics, and just wanted to highlight that as well. Great.
Tim, did you want to come in?
Yes, I think just from a Leeds point of view, the 3 sites originally planned were Armley, Beeston and Seacroft, and that is particularly driven by health inequalities type issues. There are clearly challenges with delivering some of those for various reasons, but that was absolutely one of the drivers. So.
Okay, thank you, AC. So it's great to hear that in practice as well. Okay, coming over to you, Fatima, and then Harris.
Can you hear me okay? Yeah. So, Rob, you did a really helpful summary of that report, but there was so much work in there that I think sometimes people don't fully appreciate the hard work and contributions of people that aren't always visible in patient-facing services, and in a sort of narrative which is very focused on mismanagement or too many managers or performance management. I think sometimes we need to actually really shout about the contributions of people that are day in, day out enabling us to deliver services that people rely on every single day. The other thing was to say a specific thank you on behalf of our staff networks, which is a part of the role that I have here on this board, to Jonathan Webb for his proactive response to the letter from the former Secretary of State about the contribution or focus on EDI. Many colleagues were distressed and unhappy to see the letter, but what was really wonderful to see was the detailed and really well-structured narrative of the contribution of the agenda. But what was even more empowering to see was just how well embedded it was across the system, and that it wasn't just an add-on to the work of the partnership, but actually something that is part of our day-to-day business. So I suppose what I'm trying to say is, as we enter, I suppose, one of the challenging periods of the NHS, which is winter, and also forthcoming to more public uncertainty, particularly with the context of potentially more strikes and an increase in the cost of living crisis, how do we continue to ensure that the values and behaviours that make West Yorkshire what it is continue to remain front and centre? And how can we support colleagues beyond our health and care system as influencers and anchor institutions to continue to support the work that we're doing here? Because we can't do it in isolation. If we truly want to address some of the situations that are manifesting in our GP practices or in our consultation rooms, then we need to work collaboratively with our partners. And that requires us to be courageous and to show the art of the possible, I guess.
Thank you very much, Fatima, and thank you, Jonathan, for deputising for Rob that day, and while Rob was on leave. So, Rob, do you want to respond to Fatima's point, and then we'll come to you, Harris?
Yeah, I think so. So we're all leaders here, aren't we? And I think we've got to demonstrate that we're leaders with the right values that link with the Nolan principles and help to set the tone. We are part of a political system, and political leadership comes from all sorts of places in our system. We have really fantastic local councillors. We've got a politically led partnership board. We've got local MPs who work closely with us. There will be some campaigning. We might not agree with some of it. We are public servants, and we operate in an environment where we have to deliver against the mandate set by the government and NHS England. And it was useful that the Secretary of State's letter, for example, asked us to do something. It didn't direct us, so we could therefore decide what the right thing to do was. So I think all of us around the table, we could give a response which is very much about structure or governance, but this is personal, I think. Why have we all been recruited? How have we been recruited? Well, we've been recruited on the basis of what we believe in, what we value as much as what we do, and we just continue to demonstrate that throughout what's going to be quite a tricky period. And that might require a bit of courage, and you will probably, as somebody said at Heather Nelson's celebration last week, Heather Nelson, former Chief Executive of the Black Health Initiative, who sadly died this year, if you do the right thing, you have to stick your head above the parapet, and somebody's probably going to try and knock it off. But you still need to do it.
Thank you, Rob. And I know for you, Fatima, in your role as inclusivity champion, this is a key role where you connect with this board as well as our partnership as well. So there's a number of things we can take forward and link with our partnership board, which will be in Halifax on the 5th of December. Harris.
Just two questions, one bit on the cost of living crisis and one on elective care. Rob, I really appreciated your reference to the CQC State of Care report. Regarding the cost of living crisis, what initiatives are taking place in West York to ensure equitable access to care, especially for individuals struggling to travel to doctor's appointments or facing challenges in affording prescription costs? Because that will make winter pressures far worse. And also shifting the focus, looking at the cost of living crisis and workforce, what additional support measures are being implemented for staff, particularly those in the community who rely on their own vehicles to travel? And I know subsidies exist, but is there adequate consideration of this broader cost of living challenges? And my second question on elective care, 275,000 people is a lot on the wait list. So what specific strategies are in place to ensure that individuals on the wait list don't deteriorate in their health status? And with a focus on prioritisation, particularly for surgeries, are there any initiatives that are being taken to optimise this process? I've heard of approaches such as a trust, I don't think it's in West Yorkshire, prioritising based on social need, considering factors such as work, such as prioritising a hip replacement for Andrew, who's a builder who's been off work for 6 months, which has had a massive impact on him, over John, a lawyer who can work from home. So in the West Yorkshire region, is there any noteworthy examples of best practice?
Okay, so on the first of those, I think Kate's left the room around the staffing, so I might come back to that in a moment. But the cost of living crisis and the impact upon communities and staff is something that we've been focusing on for some time. And Debs Harkins from Calderdale led some work with the local authority, Director of Public Health and colleagues around this table to say, what are we all doing collectively and how do we signpost people into what's available for support, whether that's through general practice, through drop-in centres, through their connections to social care, etc. So all of those resources are available and connected to the work of the Mayor and the combined authority. I'm very happy for Rachel or Tom or others to come in and describe any more of that. There have been some discussions with staff side around what do we need to do for our staff facing additional fuel costs or travel costs, etc. And I know that some of our providers have made some changes to some of those arrangements. I can see Karen's nodding her head, particularly in community services, where staff are more likely to be using their vehicles, or in mental health care. Kate may add some more, more to that, because some of this will be linked into what staff side arrangements there are and making sure that we have some fair and equitable treatments. In terms of waiting, clearly we've already got good practice on issues like people with a learning disability being prioritised. We've got award-winning work in Mid-Yorkshire Hospitals Teaching Trust and in Calderdale and Huddersfield Foundation Trust. There are a range of other bits of work around waiting well, but I'm going to pass over to Brendan, as our West Yorkshire Association of Acute Trusts is responsible for elective recovery, supported by ICB colleagues, and Brendan may have some additional things to add.
Thanks, Harry. So I think the waiting well piece that's the crucial piece to this. What does it really mean for people sat at home? Not necessarily sat at home, who may be having to live a very complex and difficult life whilst they're awaiting intervention. So there is what does that mean for you? I think, as Rob said, we've looked at what do we do for our communities with an LD diagnosis, or indeed to some of the conversations earlier who are coming from areas of challenge. So it's easy to categorise people in IMD categories, but it's much broader than that. I don't think we've got to the space that you've described about whether we actually make a judgment over a builder or a lawyer. I don't think we've got to that space. I think we've got to the space about what does it mean for individuals and indeed their families. So some of this speaks to the patient, but we're also paying attention to what does it mean for their families. Because there are spouses who are working or indeed unable to work. There are people who are caring for elderly relatives and sick partners or friends, and then there's the whole childcare debate within all of this. So I think we've got a process, but it's something we've continually paid attention to. I think you would easily say this is our chief nurses and medical directors who have paid attention to this, and they absolutely have, and have looked at the risk and the quality element of this for our patients. But I'd argue our chief operating officers would be able to articulate this in the same way, which I think speaks to how we are looking at this and the approach that we're taking. And it also speaks to the conversation today. We're not working at this in isolation. Richard called out, elective recovery in this country will be predicated on the cohesive relationship between primary and secondary care. It's not one or the other. I'd argue for my colleague to the right, it's also about what's happening for children and patients with a mental health waiting for services. It's also what's happening for Karen and her services. And I'd also just add, our colleagues are our communities are our colleagues. We're paying attention to that. The fuel piece, I'd just say as well, Rob, we did increase our fuel costs for our community colleagues when we saw fuel prices rise, and we did that collectively, so it wasn't a case of one organisation having a rise and others not. And we went up together, we came down together. It's something we'll need to keep paying attention to.
That's really helpful. I know, Karen, from Community Services point of view, it seems that Brendan has covered that. Sarah, do you want to come in? And then I do want us to move us on to the next item. So, Sarah.
Yeah, it's just in terms of where we talk about prioritisation based on different needs and categorisations, and I think we need to be really considered in what we're asking our clinical services to make those judgments based on, knowing some of the announcements that have been indicated are going to come tomorrow. I think, you know, the point was made earlier in terms of when we were talking about primary care and what Becky articulated. We have the biggest problem is for people who are in the most extreme levels of poverty being able to access any services. So then to ask our clinical staff to form judgments based on different categories of employment and what's seen as more valued than another, I think we would be straying into territory that would be hard for our clinicians to be expected to justify, when absolutely we know that we've still got that huge poverty gap and a gap in terms of, as you said, any domain, people with a learning disability have the worst access and outcomes before you factor anything else on. So, yeah, it's being considered in what we're expecting of our clinical staff around their prioritisation.
I forgot to mention, we're paying attention to the do not attends. Actually, that speaks to why, it's to Sarah's point, why are people not attending appointments? It's because they can't afford transport, or is the timing of it wrong? And that speaks to again to the CDC conversation. How do we deliver services differently?
Rob, do you want to conclude this?
Yeah, just a final bit on that. So just to give Brendan's organisation, you know, a shout out for the work that they did on Harris. If you look at, you know, who's waiting and how long they're waiting based on some protected characteristics and deprivation, that didn't appear equal. So some work was done to make sure that was equal, so people weren't affected disproportionately or waited longer because they were in a poorer part of Calderdale and Huddersfield, or because they had a learning disability, etc. So as a minimum, we need to be doing that. I think the other thing I would give a shout out to is the work we're doing with Yorkshire Ambulance Service, all of our acute hospitals, and the Health Innovation Network, formerly the Academic Health Science Network, on who's conveyed to hospital, who rings the ambulance, and what happens to them. And that demonstrates that there are different communities calling ambulances for different reasons, often which could have had a different intervention, which may be linked to waiting or maybe linked to their social situation. So we're continuing to look at these issues and then act upon them. But as Sarah said, making positive choice about some things will be fairly fraught with moral hazard, I think.
AC, do you want to follow up? Just ask very briefly.
Thanks, Kathy. And just to sort of follow on with what Brendan said, and linking up with the previous conversation around the primary care RCGP guidance on specifically looking at the interface, I think it will be useful to see how that interface is maturing when we come back in March again, specifically around this waiting well initiative, so that those patients are looked at in places and some evidence on that improving working relationship with primary care and secondary care around the waiting list.
And also taking on board Brendan's point as well, moving it on into a more contemporary way of working in West Yorkshire as well. Okay, thank you. I'm going to move us on now, but before I do, I just wanted to note Agenda for Change pay uplift for non-NHS organisations. This is something that's been discussed at previous board meetings. The judicial review and the influencing work of Social Enterprise UK, and Karen Jackson, who sat around the table, who's played a role in that as well. So it's good news to hear that decision, but I know there's more work to be done as well on evidencing that. And lastly, as chair of the board, I just want to thank Rob and a lot of senior colleagues around this table and who are not in this room for their work at the moment on the revised operating model. We're still in staff consultation, even though it's concluding soon. I and other non-execs have been observing the staff briefing sessions and seeing a lot of the documentation that's coming out. And I'm really pleased to see that you're continually listening and then reflecting back and changing or improving communications and engagement work that you're doing. So thank you for that. It's really appreciated. And as a board, we'll hear more on that as we go into the new year. Okay. Right. We will now move on to item 9, which is a key item on system performance. So you have items here around the integrated performance dashboard with the financial performance. And if you keep that in mind, that NHS England message to us on the 8th of November about needing to live within our baseline system allocation financially, our corporate risk register as well. So we're going to hear briefly from Anthony, Jonathan and Laura at a West Yorkshire level. I invite any place leads and sector representatives to contribute on this. We can probably have about 20 minutes or so on this. Then after that, as you know, we've got winter planning, which is an update, annual assurance of emergency preparedness, resilience and response, EPRR, which is an update. And then we have our committee AAA reports to note, which should link with this item we're about to discuss now, item 9. So Anthony, Jonathan, Nora, very briefly, if you give us an update, then I'll invite place leads around the table if there's anything you want to share with us, and then we'll take any questions. I really do want to aim for this meeting to finish up at 3:40, 3:45 at the latest. So, this is an important piece. So Anthony, would you start us off, please?
Yes, thanks, Chair. So I'm Anthony Keeley. I'm the NHS England Locality Director for West Yorkshire, and I lead on planning and performance issues within the ICB. So just to remind colleagues, this is the latest available published and validated data that we present in the performance dashboard. So given that it's the latest available, it actually touches on different points in the year depending on the different indicator availability. This is the longer version of the pack that we provide for alternate meetings. So it includes detailed benchmarking information which compares West Yorkshire with the other 41 integrated care systems around the country. We've been continuing to develop this report through the year, and this version today includes some new indicators at the request of the board, covering children and young people's mental health service access, and also community services, particularly in relation to the availability of virtual wards and the standard around urgent community response. I'm conscious also that we with the focus today on primary care access, we have a number of indicators in this report on availability of appointments and that kind of thing. And just to pick up Becky's comment from earlier in the meeting, we know there's a whole lot of information which might be more interesting and more relevant to look at in future. So we are continuing to look at what we can bring into this report that's publicly available data to enrich that view of primary care access. So I'm conscious of the time, so I'll perhaps just touch on the new indicators that we put in just to give a sense of what they're telling us. So if you're following this in the meeting papers bundle on page 155, this is the new inclusion of an indicator on access to children and young people's mental health services. And what this shows us is that we're actually exceeding the numbers of access opportunities for children and young people against the target we've been set, which might sound good, but actually I think it's just a reflection of just how much pressure there is in this system, how high demand is, and how the system is working really hard just to stay ahead of demand. And Becky asked me a question in the margins around how does it actually relate to the level of demand. Now, the indicator doesn't reflect demand. I think that's an important point to note. It just reflects the level of activity we're providing. So we will take that one away to see whether we can put that in context any more effectively in future. On page 157, again, if you're looking at the meeting papers bundle, this is the new indicator on virtual ward capacity. And this shows that as a system, we're actually ahead of our plan for this point in the year on capacity in terms of numbers of virtual ward beds equivalent that are available, and also have very high utilisation rates at 88%. So there's work going on through the community provider collaborative and with colleagues across the system looking at how we can most effectively move forward with the rollout of virtual wards at the moment. But we're in a reasonable place in terms of what's there just now. And the final point I would just note on page 159 is in relation to the 2-hour urgent community response indicator, which shows, again, that we're exceeding as a system the target for 70% of people to meet that 2-hour standard. So again, I think that's as much as anything an indication of just the level of demand for that type of service. I'll just finish by saying, of course, where we are here today in November, the performance report doesn't reflect the fact that we are now really into the winter season. So we are starting to see some impact of high demand on urgent and emergency care services in particular. We can perhaps touch on that a bit later in relation to the winter paper. But we're also now seeing, I think, real impact of the last year of industrial action on things like elective care and long waiting times. So again, that's not reflected necessarily in the paper yet. It will be in the next one. So thankfully, we've seen a pause in industrial action over the last 6 or 7 weeks, and we'll have to hope that continues. But there is still a risk of further impact on elective care waiting times if there is further industrial action by consultants or junior doctors. So I'll pause there.
Anthony, thank you for that update, and thank you for continuing to take on board requests around metrics. It's good to start seeing some of those community services metrics in there, development of the primary care ones, and I appreciate having the benchmarking against all systems, all 42 systems, but particularly highlighting how we compare and contrast against our colleagues across the north with similar size systems and similar populations. So that's really helpful. Thank you. I'm going to invite Jonathan, then Laura, to give an overview of their reports, and then I'll happily take comments and questions. I think, Becky, we've got you first. So Jonathan, but to your report.
Okay, thank you, Chair. Excuse me. So the financial position set out in this paper covers the period to the end of September. So it's the month 6 financial report. That position, as reported to the board in previous months, remains challenged. So as a system, our year-to-date performance for the first 6 months of the year was to report a £51 million deficit for the system. We continue to report to NHS England a forecast deficit for the end of the year of 25 million, and that was in line with our previous sort of conversations around planning and the gap that we took on at the start of planning. As in previous months, though, despite that forecast being 25 million, we continue to risk assess our plans and deliverability of our financial plans across the 11 statutory organisations in West Yorkshire. And the most likely deficit based on that assessment at month 6 was nearer to £100 million. And that was driven by a range of issues which have emerged since we submitted our plans. Partly around industrial action costs, which I'll come on to in a moment, but partly around the rate of inflation, partly around pressure on our primary care prescribing budget, and partially around the continued access through patient choice of the independent sector. So 4 really sort of key significant issues there. To mitigate against that, organisations and places have continued to explore efficiency measures, productivity measures, continue to roll out and implement the financial control measures that were set out in NHS England's letter to us earlier in the year because of our position as a system, and continue to really drive down use of agency spend wherever possible to minimise that. Since then, as has been alluded to previously by Cathy and Rob, we have had notification from NHS England that as a result of the industrial action costs and the implications for both our financial plans and operational plans, we were asked to do a 2-week reset. And that was in part supported by some additional resources from NHS England. So there was £800 million been made available nationally to systems to support that, as well as some flexibility on elective recovery fund allocations and targets with some of the financial flexibilities. And we're going to have a conversation later on in the private board session looking at the draft plans we've received from across the system.
Thank you very much. That's a really helpful update. Laura T on the corporate risk register.
Thank you. Board members will be familiar with the format of the risk register report. So you do have the corporate risk register for your attention, plus details of the place risks that are deemed to be high level, so scoring 15 or above, and also common risk mapping, which indicates those risks that are common across 2 or more of our places. And also highlighting links to the corporate risk register. So I'd just like to flag a few areas for your attention. We do have one new risk this cycle, which has been added following discussion at Quality Committee around increasing number of people seeking asylum and the impact on demanding services. The detail of that is set out at paragraph 3.4 of the report. In terms of the high-level risks, we do now have 6 risks that are deemed to be critical and 10 serious level risks. And a lot of those will be familiar to you because we've talked about them over a number of cycles. But I did want to draw to your attention 3 risks that are increasing in score. So there is risk 2304, which is around delivery of the 23-24 financial requirement around break-even. That has an increasing risk score, the details of which are set out within the report. And there are also 2 further high-level risks that have increased in score, 2294, which relates to work on the revised operating model, and 2202, which is around the risk resulting from measures that are being taken to control expenditure in local authorities, impacting on other place providers. The increase in score for a number of our high-level risks and also the addition of that new high-level risk is continuing to add to a small but fairly steady increase in our average risk score over the last few months, which I know drew to your attention last time, but it is continuing to increase. Just to flag that the Audit Committee has asked the Risk Management Operational Group to support a focused review of risks that have a static score as we go into the new risk cycle, which will start tomorrow. We will be targeting those that have the longest standing static scores to make sure that we are doing everything that we can in terms of managing those risks. And then the final thing I just wanted to flag was that towards the end of the report in sections 5 and 6, you'll see that you have a summary of the feedback from the risk discussions that have taken place as we've worked through the risk cycle. So you have the Risk Management Operational Group, Executive Management Team, and then the discussions that have taken place at either our Finance, Investment and Performance Committee or Quality Committee. I won't go into those in detail, but just to flag that it's useful to see the discussions that have happened en route through. Thank you.
That's really helpful, Laura. And as I said earlier, then our AAA report should cross-reference with that as well. So I just wanted to, before we go to Becky and Fatima, I can see you want to ask a question. I think, Jane, you want to come in at a certain point on risk as well. Is there anything from... And Rachel, so let's get all these people down. Place colleagues, is there anything that you want to highlight particularly? Carol, do you want to go first? I don't know. And then Tim. Thank you.
Thank you. Thanks. It connects back to Anthony's report and the addition of the community indicators, which is something I know it's of interest to all of us, but we've had conversations about in Kirklees as well on the back of our recent community contract conversation. So it's helpful to start to see some of this coming through. There was 2 observations really from it, I think. One of them was, first of all, I suspect there's further conversations still to have about, are these the indicators for community that we think are the ones we really want to be looking at? Because I know, Karen, you've talked in the past, haven't you, about community waiting lists, for example, that don't get the profile that numbers on other waiting lists do. So I think maybe there's a discussion that might be in FIPSI where the Finance and Performance and Investment Subcommittee that we need to have there, just about how we continue to develop that. And I'm keen to make sure that what we develop in place is consistent with what we're developing through for West Yorkshire as well, because we want to be able to tell one story. The other bit was just a bit of an observation as well on the 2-hour response, which must relate to our urgent community response services. And there's just a bit of an irony in it, which is noting the comment about it being difficult to capture the Kirklees data at the moment because it is an alliance of providers in Kirklees who deliver that service. So on the one hand, I think we probably feel really proud of the fact we've got a provider alliance delivering that service, but on the other, it's now causing a problem because the data doesn't flow nice and neatly. So there's probably just something to clock there that I think our alliance model is a really good thing and something we're pretty proud of. But I did note in the report it starts to make some of the information look a bit strange. So just
okay, yeah, the data needs to work with what's working on the ground. Yeah, that's really helpful. Thank you. We're going to go to Tim, then we'll go over to Joe. Tim.
Yeah, thank you. Tim Riley, Place Lead for Place of Leeds. Just a couple of things. One around the primary care data, because I think it really is quite interesting how it illustrates some of the points in the earlier discussion. So Leeds has a relatively low, I say relatively because it's West Yorkshire, low number of appointments and yet pretty good satisfaction. And we looked into this and we've come up with a number of hypotheses about why it's low. And there is not yet an answer. not a really clear answer. Is it something about the data capture? Is it something about the workforce? Is it the conversation around estates that actually we know some of our GP practices could put on more but can't? Different types of appointments, are they being recorded in the wrong way? So there's a whole set of questions that we've looked at and have not yet got, I don't think, got a really clear answer to. And I think that goes to me to the heart of exactly the same point you were making, Carol, about how we use data and using it to learn rather than, and I think you said this earlier, Becky, rather than holding practices into some sort of judgment or whatever it is. I think there's a learning opportunity that some of this gives. Similarly, I think around urgent care, and we're obviously going to talk about winter later, we have had some really important, made some real progress. If you'd asked me this time last year, No Reason to Reside was running at about 23%, 24% in Leeds. It's down to 13, 14% most days now in Leeds. That's really, really good progress. Now, interestingly, then when you look at the performance data around urgent care, what you see is A&E, we're doing okay. We're making good progress on to hit our trajectory. 12-hour wait, not so good. Ambulance turnaround, still we know is good. But still high occupancy. So when you look at that collectively, you go, what is going on? And I think there's something really important about us using data in a way that it allows us to explore and learn. It goes back to our values and our behaviour, rather than, well, that must mean that's no good or that's great. Actually, the combination of some of these is quite complex. And we need to go on learning from that and trying to understand what's going on in the detail behind it.
Thank you. I think you've both, we're going to come to Joe, who may complement what you've just said, but there's something there, Anthony, again, looking at this report, but maybe something, we've got the January and the March board meetings, we can finesse this. I think there's something, a point there about working with Karen and the community collaborative on those metrics, but this is good progress we're making. I mean, you think where we started off in our first full board meeting in public in September last year and looking at these kind of data sets. So, Tim, I think that's a really good point about we're putting these metrics in to work out what we need to pay attention to. And there's something about risk and performance, isn't there? But your point also is about what we can learn from it as well, which I think is really helpful. So, Joe, to you, and then we'll go to our colleagues who want to comment or ask questions. Becky, Jane, Fatima, Rachel. So, but Joe, over to Wakefield.
Thank you. Joe Webster, Wakefield Place lead. I just thought I'd share with you a couple of statistics that are not contained within the report that relate to some of the conversations that we've had today, but really emphasise stepping into that brave world of innovation and doing things differently. So one of them is about our shared referral pathway, and that we share with Kirklees. We work across Kirklees, Mid-Yorkshire and Wakefield, and links to elective recovery. So Harris's point about how we are supporting, working differently for elective recovery. So if I just read out some statistics on a month. So 3,800 people are referred using shared referral pathway, which is a different way of engaging across primary and secondary care in Wakefield, looking at cases very differently. And that's resulted in 250 fewer appointments than what we did the previous year. 257 patients avoiding unnecessary diagnostic services, 126 patients a month getting reassurance in 2 days that they don't need to be seen by a clinician, and 121 work days saved. So back to the wider determinants of health. We've even tracked how many school days are saved because people actually have time off work to go to appointments. We think it's about 2,179 reduction in travel costs and 3,042 road miles. So it even actually contributes to the climate change. That's the power of, I think, working very differently. And if you link that to then some of the virtual ward concepts, I think that the virtual ward is another great example. We had, it's about a year, isn't it, 2 weeks ago that we've been running virtual ward. And we saw over 992 people in our virtual ward programme. And I think the impact on that in terms of their experience of care is phenomenal, and their outcomes, because they're being delivered, they're being supported to be independent in their own home. And I think that's been supported by a really dedicated team and a great example of partnership working. So all those go to some of the performance statistics that I think we're seeing here today, but link to some of the conversations that we've had. And I forgot to tell you that everybody in Wakefield that's been waiting over 52 weeks has been contacted by our social prescribing link workers that are residing in general practice. And they've been asked if they need help whilst they're waiting for their care. And over 70% of people over 35 weeks waiting on a hospital waiting list have also been contacted as well. So I think they're just examples of, and I know that all my colleagues are doing that to some different levels, of how we drive performance through working differently.
That's great. Thank you very much. It's great to hear some perspectives on not only data, learning and practice that's going on in places. Thank you for sharing those. So we're going to go now. I just ask colleagues to keep their comments or questions brief. We'll take them in this order, and then we'll ask colleagues who are presenting the reports to reflect. So Becky, Jane, Fatima, Rachel, Kim. So Becky, to you first.
So thank you. I just think our dashboard it looks a bit NHS Englandy, and I wonder whether we should make it a bit more health watchy. So how are we responding to our population's concerns, not just NHS England's concerns? That was the first point. And then the second thing is just a couple of things around language. So we keep talking about industrial action rather than the government's inability to settle the pay dispute. There's just something about where it looks like blame's lying. So I'm just want to paraphrase that. And then in the dashboard itself and your commentary, we've got something here about there's been a surge in demand for children and young people's mental health. I think it's something that's going to stay. We've said this many times over. So it's not really a surge. It's a new level of demand. And I think we should be just careful about our language, or perhaps be clear about our language. And then I think as we're replying the dashboard, what was really helpful to hear from places, which is what are the questions the dashboard's trying to answer? So when we look at our children and young people's, that's why I think, Anthony, they're just, are we hitting some notional target about how many kids are accessing stuff, children and young people are accessing stuff? It doesn't matter if the demand is like this, that we've got this many. So I think we have to think, what questions do we want our dashboard to tell us? And so when we look at primary care, if you look at Kirklees, we've got lots of face-to-face, not so many telephone. Is not so many telephone good or bad? But the patient satisfaction is great. So in the round, it looks great. But it's in the round that it matters. So that means we have to look at trends, not just where we are now. So if we look at primary care last year, it was really helpful this morning was hearing from everybody about why the public satisfaction general practice has gone up and down. So Robin, hearing from you saying, we know the practice is where it's gone down and this is what we're doing about it. Or we haven't heard yet, Bradford's has gone down, Wakefield's has gone up, but you know why, Joe, and you know what you've done about it. So then you've got a better nuance. So it isn't just the dashboard in itself. We can see where we've done the right thing and it's worked, or where we need to step in and what we should do about that. And so the same thing for me in terms of patterns and trends. There's one question that I'm not clear about, which is in relation to the ambulance and handovers and some of what you were saying, Tim, is we're seeing the same sort of pattern as last year. Is the pattern going to manifest itself into the same issue as last year? I think I hear not, but it'd be helpful, I think, for us to say that here for people who are listening and watching, which is we've got that increase going on. Is it going to look like last year or not? That'd be helpful. Thank you.
Thank you. I mean, Becky, with the dashboard, we can finesse it from meeting to meeting, from January to March, and then I suggest after our March board meeting, we'll take a moment of reflection and see where we've got to, and again, gather a few of us together to see where we're going with that. And your particular point on questions that we need to be asking. We'll go through the comments and questions from other colleagues, but I wanted to, after that, invite Rob and Bev, if you would, just from your side as ICB executives, just that point on working with Yorkshire Ambulance Service, and Bev, whether you just give us an update on maternity services as well. That's that round around safety that's coming through on these reports on maternity services. That would be really welcomed. So Jane, can we come to you? So we won't lose that point, but we'll come to you shortly. Jane.
Yeah, thanks, Kathy. A few questions and reflections, actually. I really like in the performance report. I do think looking at the comparator, the benchmark data against the other ICBs is really helpful. I think it'd be nice in future when we do get those reports to have a little bit of a narrative, just to keep, there's some great positioning that we're in, And there's also some challenging stuff, and not surprisingly, helpful at the board to kind of where there looks more challenging to get some insight as to whether it's an anomaly because there's such a different comparator group for whatever reason, or whether there's something there that we should be, trying to explore, push ourselves harder in terms of our own targets. But I think I think that will prove really helpful for us going forward. I did do a bit of a sort of review across the whole kind of risk piece, as I do as chair of audit committee, etc. And I guess I still think we've got masses of engagement in the whole sort of risk landscape, which I think is great. So I think our starting point is really impressive, both across corporate and in the places. There's a richness of stuff. I am still worried, though, whether we're using it and whether we're keeping it as refreshed as would be helpful to us. So Laura mentioned at the last audit committee, and it's in our AAA report, the sort of concern around the number of static risks, and not just how many static, period on period, but 4 or 5 periods and static. And that, to me, in the role that audit committee has around are the processes working for risk management, would suggest, you would expect some more live updates to the risks. So I'm really keen that people do, focus on that. And I guess then I started thinking about how could we have more evidence that, because there will be occasions where things are static, of course, but how do I know kind of where we should be pushing a bit harder? So I still think, Laura, showing a sort of target date for the target risks. So in all cases, when you get into the detail, you have a target risk level that you're trying to get down to, but we don't say by when, and that would also help calibrate, because some we know will take longer than others, but there should be some, hopefully, that we'd expect to see some movement on, and then we can, see whether that is progressing as planned. So if we're able to build that in, I think that'd be helpful. There are some areas where things just, there are things that we've discussed here at the board. Last time we talked about the Summit for Neurodivergence at the beginning of December. It doesn't feature in the risk register in terms of a new control, so that would suggest it's probably not been updated. So encouragement around that. I think peer review across the place risk registers would be really helpful. There's a real mixture when you get into some of the appendices in terms of the number of critical risks in some places versus others. Looks a little, you could look at it and think, should be really concerned about a place, or have we just got a different sort of calibration across? So I think that would be something helpful. And then earlier in the conversation today, when we're talking about general practice and primary care, it was interesting from my perspective to sort of start looking through to the papers and see how much that was coming forward in the risk register, and not really, not in the same way that children and young people's mental health is, not in the way that VCSE does quite dominantly, as does WIAT, maternity and natal. But the big discussion that we had earlier today isn't yet coming through, and I was slightly surprised, bearing in mind the sort of rich discussion we had, and responding to some of the challenges particularly raised by our population that we serve. So some reflections in terms of encouragement to sort of try and make sure we're even more thorough, making ourselves able to use this to make sure we're focusing in the right places. Thank you.
Jen, that's really helpful. Thank you. Laura's nodding, so I don't think there's anything controversial that you've said. And I'm pleased both from you and Becky, what you're doing is you're encouraging us to continually improve, finesse, enhance what we're doing, which is really welcome, to make sure everything is joining up and connecting. Great. So we're noting that down. Jane, Fatima, then Rachel, then Kim, then Majid.
I feel so sorry for Anthony, because every time we get this report, we're like, Anthony, we really like it, but can you change this, and can you tweak that, and can you change this? And I'm sorry, but I'm also going to join the party of constructive feedback. So I think that this is a fantastic report which demonstrates the value for money that this health and care system delivers. I worry that if you're someone who's watching it on a webcast, you don't get that message because it's framed in a way that is NHS speak. So going back to Becky's point of Health Watch language, or language that the public fully appreciates, I really love the way Joe framed it of, you know, the work we do in this health and care system impacts the wider economy. We saw in the press, didn't we, a few days ago about the fact that there's so many people waiting to access care that is impacting our employment market. But there are other things that we are doing that is supporting people to go to school, to go to work. So I just wonder whether there is a sort of a front sheet or an elevator pitch that we could have preceding this report that answers a little bit of the so what question. So yes, we're doing the things we should be and we're on track, but these are the bits that actually we really need to be showcasing so that I can, with local government and with the mayor and all the other partners that I work with, can articulate the things that we're doing well, but also opportunities that we could potentially, with the support of our other sectors, address. The other thing, and it's linking back to Jonathan's report, was being asked to deliver within a financial envelope within a situation where the world is literally on fire is a bit of an ask, isn't it? And we're heading into potentially a really challenging cost of living crisis. We're heading into winter, which means people will be struggling even more. And also there are significant concerns with the local authorities' budgets, and the voluntary community sector are already really struggling. Have we factored in that within the projections and what we're aiming towards for March, but also using our influence as people around this table to push back a little bit about what is realistic and proportionate? And then the final one, and Laura, I love your risk report. It's really helpful because even as a novice like me, I can get my head around it. I do wonder whether we need to acknowledge the financial situations of our local authority colleagues and the implications that might have for the services and impact within the health and care system. Because if they're taking decisions that are impacting services that will have a knock-on effect to our services, we need to acknowledge that somewhere. And if we're doing it with the VCSE, I think we should do it with the local authority as well. But it's just a suggestion.
Thank you, Fatima. I think we've got that risk some way, and I think we need to finesse it and make it stronger, basically. And I know there's been some experiences in Kirklees, for example, where there has been some learning, hasn't there, on the ways in which the NHS and local authorities are working together on service planning and unfortunate changes to some services. OK, thank you. Colleagues, I'm going to come to you now and just ask you to be brief, if you would, just so that we can finish up on time, but I don't want to lose your contributions. We've got Rachel, Kim, Majid, AC and Tom. Rachel.
Thank you. I just want to reiterate Jane's point about target risk score, because I do think what it helps to do is to show what's in our gift versus what is a national issue. And actually, it stops people assuming you go from 25 to 0 and that's your ambition. So I think that's definitely a way forward. I did look particularly at the risk register this time. So 3 points. One is the one about COVID. I suppose it's just making sure we don't lose sight that if we get a particularly bad flu season, that would equally have an impact. So sometimes just saying COVID isn't necessarily indicative of what also puts pressure on the system more broadly. The second point is in relation to asylum. I think the health protection elements of that is a really important part of that risk, because actually, you know, if people are coming from countries where perhaps the vaccination, immunisation, all of that is not to the same level, clearly that creates a pressure, and it's just making sure that's captured. But I'm very much aware that it is a really challenging situation, and particularly given probably the trauma that these people have experienced. So it's how we wrap around with that. And then finally, on the maternity risk, I think I entirely understand the whole concept of kind of staffing ratios and safety from a internal clinic perspective, but I just don't want to lose the point about it's not just women's experience that will be affected by closing birthing centres. It's actually potentially a higher risk pregnancy, because they won't be able to either have the time or the money to access a service that is significantly further away. So I know colleagues in that system have got that covered, but I just think it's really important that we all remember that, because sometimes looking at things on a setting by setting basis doesn't capture the risk in its entirety.
That's really helpful, thank you. That and the target risk score to what you have just shared there as well. And we're going to come to Bevan in a moment on a maternity services update, and it was something that came up at the last partnership board as well. Thank you for that. Kim, Majid, AC, Tom, and then Bevan wanted to come over to you on maternity services. Kim.
Thanks. I just wanted to pick up on risk 2120, risk of loss of VCSE services, because we did knock that risk down as part of a calibration of risk assessment. I did bring a paper a couple of weeks ago to System Programmes and Transformation, I think it's called, because there is a real feeling that that risk has escalated into more of an issue that is being felt now. So we're doing some important work that I think it's useful to share with the board. With Jonathan's team, we've done an initial analysis of, I think, 249 ICB contracts with the VCSE across West Yorkshire. 70% of those are due to end at the end of March next year. So that is a pretty stark reality for us. We had a really good discussion. We've asked all our places and our VCSE leads to have a look at that a bit in more detail. The feedback, the anecdotal feedback we get from the sector is that the reason why some of that risk has crystallised into more of an issue is in the context of the financial pressures, and therefore in obviously an important attempt to balance the books, there is a risk and a danger that the VCSE contracts are the first to go or to be brought to an end, and that is very much being felt on the ground. So we are picking that up proactively, but I thought it was important to raise with the board. And therefore, we may need to look at that risk score again.
Yes, okay. So there's something as we come into, well, we can come to the January board meeting, but we need to do more before January. I think, Jonathan, that is something for a note and action as well. I'm just going to carry on getting through questions and comments, but thank you, Kim, for sharing that. And thank you for inviting me to your development session that you held last week, which I thought was really helpful to sit with voluntary and community and social enterprise sector leaders to discuss the challenges, the opportunities and that breadth and depth of health and care, which was great, as well as the issues they're facing. Majid, then AC, then Tom.
Thank you. 2 quick points. One, it's good to see us amongst colleagues in a league table, but be good to see what we're doing in terms of learning. So those similar sort of systems, which have got a much higher sort of rating score or whatever you want to call it in some of these areas, it'd be good to see what are they doing and what can we learn from there, not just look at them in a league table. Second point, I know this has been brought up a number of times about demographics and inequalities. We can't obviously start with everything, but it'd be good to pick 3 or 4 key areas where we go into a bit more detail and look at the variations by demographic and understand where those inequalities are and what we can do about it. Thank you.
Thank you, Majid. I think this helps us work with Anthony to finesse the dashboard over the next 2 meetings, and then also do a review of it into the spring. AC.
Just a quick response to what we have been discussing in FEPC. I think we have an action on creating the trend table that Becky was talking about. So in the next meeting and future meetings, we will see the trend tables coming up. Second is the discussion around, of course, what is required for the next phase of the dashboard development. And I think we have had discussions around picking it early in spring next year as the operating model discussion sets in, to understand what the places would benefit from, what the questions need to be asked in places, but at a system level, and then drive the discussion forward, specifically to close the loop, feedback loop that HealthWatch was talking about, and connecting the dashboard alongside that so that we have a comms approach to getting back to the service users.
Thank you very much. And it's going back to earlier points that Tim and Becky had made, though we do need a reporting dashboard to deliver and demonstrate to NHS England we're delivering on the targets that we are bound by and contracted by, as well as what we wish to want to deliver and how we work across our places in common. OK, thank you. Tom, do you want to come in then?
Thank you, Chair. Yeah, just to support the, I think it's really good progress in terms of the way this is presented, and just to support the comment about how we make it even more user-friendly. Having a story behind the numbers is something that we've used on outcome-based accountability, which is really helpful in trying to help people focus on that sort of contextual bit that is missing sometimes. So you've got the commentary on each of the pages, but I think it could benefit from a bit more of that storytelling. And then on the really helpful suggestion about local government finances on risk, I think that is right. And I think, as you said, it needs maybe nuancing and amplifying. I would suggest that is done on specifically around early intervention and prevention, and the link to the risk to inequalities and the risk to VCS. I think they're the sort of main area that if we look across the region, that's where it could hit. So as Majid said and others have said, I think that risk to inequalities is probably the biggest one, because they're the people who'll need these services more, and that's where you can make the biggest impact.
So that feels a priority on the run-up to Christmas, even though despite a busy time through place committees, through our other ICB committees, as well as, Tim, your point much earlier in the meeting about the executive forums as well as they're coming together. OK. I want to go to Bev just to talk about elements in the report, particularly around maternity services and safety. Bev, I don't know if you can touch on ambulance services as well, and then I'm going to have to bring us on to the next item.
Thanks, Chair. Beverly Geary, Director of Nursing. So it feels like another week, another report in the national press about how poor maternity services are nationally. And I do often wonder what women who are accessing these services and families who are accessing these services must think. But I also think always about the people that are providing these services, because I think that out of any service that we provide, this seems to be the one that's under the most scrutiny. And this dates back to 2016, Bill Kirkhope. So I think in the report last week it was cited that 67% weren't good enough. What does not good enough mean? We know that all services are subject to CQC inspections. All but one of our services have been inspected in West Yorkshire, the majority of which have improved from previous ratings. Now, that needs to be taken with a pinch of salt, because we're told we can't compare because previous ratings to this, because it's a different regime, which is fine. But if you look at one of the really key findings from the Ockenden report, and actually from Kirkhope as well, was it around cultural aspects of services. And all but one of our services have got rated as good for well-led. And I think that's to be celebrated, given the context in which we're operating. Our peer review visits are underway. I think we've done 3. We've got another 2 next week and another one the week after. We've moved on to January, I think. We will share the findings of those at LNMS board and with Quality Committee when they're concluded. In the risk register, we know, because it's historic, we've got a risk around maternity staffing, midwives in particular. There's some really good news around that, but we've got to take it kind of, with some caution. So I was at the Regional Workforce Transformation Committee, and there are significant numbers of newly registered midwives coming into all of our region, but we've got significant numbers coming into West Yorkshire between the months of late September and January, which will significantly reduce our gap if no one else retires, leaves the service, etc. The word of caution that I would give is that we've got high numbers of, ironically, maternity leave, but perhaps unsurprisingly, because of the scrutiny and because of the workload, we've got high levels of sickness and long-term sickness in midwives in particular. I think that we've got significant scrutiny on these services, regionally, nationally, locally, and at each provider board, because of the findings of the national reports. And I don't think that's going to go anywhere. I think that the scrutiny will continue. And I think that through our Maternity Voices partnership and through our LNMS and through our providers, we need to support the staff as well as the users of these services. Thanks, Chair.
Bev, thank you very much. And I think in following up on this, please talk with Becky as the new Quality Committee Chair on how you might want to bring this to board for January and March as well, whether it's through the AAA report or whether you want to do a particular spotlight on work that you're doing. Sarah, did you want to come through over, and then we'll go to Rob?
Yeah, it's just triggered by what Bev was saying there in terms of the impact on the workforce. And we do know when we've looked at the professional groups accessing the Staff Health and Wellbeing Hub, midwives in particular as a cohort, are a big user compared to other professional groups, which I think just confirms what Bev has said, but it also reinforces to us that they know the support's available and are accessing that support through the hub.
Bev?
Do you want me to talk about ambulance services? or do you want me to hold it for a minute?
Needs to put my mic on. I think that's a really helpful update on maternity services, and I'd really welcome following that up in January and March. I think there's anything then on ambulance services, and then I want to come over to Rob.
So in terms of Yorkshire Ambulance Service, I chair the West Yorkshire Quality Oversight Group. That's on behalf of 3 of the ICBs. I think in terms of the question posed, Becky, will it be the same as last year? I think, well, if the work that's been done in terms of quality improvement at YAS with provider organisations comes to fruition, it shouldn't be. However, again, there's a massive limiting factor, which is workforce. So they've got a really ambitious recruitment plan, and they're not achieving what they want to do in terms of narrowing the gap for all arms of the service. There's a new director post around quality. It's so we've no longer got a director of nursing there. It's a director of forgot. No, it's a discipline.
There's a chief paramedic.
It's a chief paramedic. Thank you for that, Anthony. Rescued again by you. So we've got a chief paramedic, and the work that we're doing with the paramedics, in particular in terms of looking at alternatives as well to conveyance, Becky, is another thing that will be helped. I think that there's some work that we've shared in West Yorkshire across the region in terms of this quality improvement. So we've had significant impacts in Mid Yorkshire. We've also had significant impact in Leeds, and at the last quality improvement group, Leeds presented the work that they've done, but it takes significant buy-in at organisation and service level. So we know that Leeds, for example, it was a board decision that no one would wait in an ambulance. But we see the impact in potential longer waits in ED. So every action has a consequence. So I think that, as I've said, there's a significant amount of work that's been undertaken. The limiting factor will be what activity that we have in winter and also the workforce. Thank you.
Thank you, Bev. That's really helpful. Rob, do you want to just share some reflections, then we'll move on to winter planning?
So I might pick this up a bit in winter planning, but just to touch on the ambulances again. So the plans that they've got, which are the refresh, given the additional resources, etc., are much better than the plans they had last year. And the evidence from our public health colleagues is that the triple whammy we had last year, one element of which was totally unexpected, isn't at the same level this year around respiratory illness. So we shouldn't expect the same levels of demand at this point, though there will be substantial pressure in the service. So things should be better around ambulances, and we continue to keep a focus on that. Some of that's beyond our control because it's about what goes on in North Yorkshire, Humber and North Yorkshire and South Yorkshire, and we work closely with colleagues on those issues. I just thought, Chair, it's worth just reflecting on a few things and recommending some actions from that. So I think there is, as was highlighted in the risk report by Laura, there is an escalated risk around local authority budget setting and the consequences for us. I think we do need, therefore, to action the work we said we've been doing around joint planning. So we're about to go into a planning cycle. We haven't got the guidance, but it doesn't matter to some extent because we really sort of know what we're going to have to do and sort of know how much we'll get, so we might as well get on with it. And that planning should be done in concert with local government. So Jonathan and colleagues are trying to do that. So I think that's the first thing that we should note here. And maybe we should get an update on that next time.
Yep.
The second thing then is I want us to much more explicitly link the indicators and the dashboard to the business, to the plan and the business plan of this organisation. So that we're very clearly saying, look, we've said we'll deliver these things, here's the trajectories, this is what it says in the balanced scorecard. So rather than wait to the spring to refresh, we should get as far as possible in the planning cycle into reporting against that. And therefore, things will become much tighter here and much more closely linked to what goes on in places. So I think that's the second thing I would suggest. So in March, really, when we sign off the plan, we should also sign off what the indicators are in the dashboard and what the trajectories are. That then, I think, links to data. And Dean Royals talks about how you can't integrate care without integrating the workforce. And Webster's addendum to that is, and you can't integrate care without integrating the data. So we're about to appoint a CDIO, and one of their roles is to oversee the data and intelligence functions that we have we need to get much better at integrating the data. You know, the kind of story that Tim told in a place, or the kind of integration between what goes on in place and what goes on across West Yorkshire. So we should make sure that that's included in their work plan as soon as they are appointed, would be the other action I would suggest.
I'm really supportive of that, so thank you. Okay, colleagues around the table, supportive? Okay, thank you. And we also have a board development session looking at committees, those on ICB committees on the 19th of December. And we also, as I've said, have got a partnership board on the 5th of December, which will have a private development session and discussion as well as a meeting in public. So I think that all plays to what you've just talked about there. Okay, thank you. The next two items are from Anthony, which are updates. You have an update in item 10 on winter planning and an update on the annual assurance of emergency preparedness, resilience and response in item 11. Anthony, what would you, if you take the two items together, please, would you just give us a brief update on item 10 and item 11, and then we can take any questions or comments. I know that you want to be very open in the work that we're doing.
Sure, thanks, Chair. So on the winter plan, we said at the last meeting we'd bring an update at each meeting through the winter on how we're progressing with our mitigations to deal with increased levels of demand and operational pressure through the winter. So this is a routine update on the plan that we discussed last time. I'll just pick out 5 headlines in terms of the ongoing work. First of all, around the time we were having a discussion at the board in September, we were doing a review of our capacity plans ahead of the winter, and we confirmed through that the plans we had around making sure we had sufficient beds open through the winter, those plans remain valid and we haven't had to adjust them. So that just confirmed, I think, that we'd done some really effective work with colleagues across West Yorkshire on making sure the right capacity is in place, and that has been maintained. Colleagues across the system took part in a desktop exercise to test a range of winter planning scenarios in October. That was, I think, really welcome opportunity just to check whether the winter plans were addressing the right kind of risks. And there's a number of points of learning which are covered in the paper, which have been shared back with systems and have helped us to continue to reiterate the plans. We've talked already in the meeting today about the rapid review of operational and financial plans that's now going on as part of our preparations. I won't say any more about that. I think we've covered that. And I suppose just to note that the ICB has launched its winter communications plan, thanks to Karen Coleman at the back of the room. So the Together We Can campaign is now up and running and helping to get the right messaging out to the community and population around how best to access services in the context of the NHS being open and available, but also under some operational pressure at some points in the winter. So those are the points on the winter update. Just moving on to emergency preparedness, resilience and response update. So this paper just presents the outcome of the annual assurance against the core standards that the NHS sets for all organisations around our availability to respond to incidents and disruptions. Just wanted to, I suppose, note that there's been a substantial change to the process for this assurance this year, and that's really in the context of our EPRR colleagues and functions being under, I suppose, a significant amount of pressure over a number of years now. If you think about the pandemic response, things like the Manchester Arena and the Grenfell disaster, the implications of those in terms of looking at organisational preparedness, and of course the industrial action that's been taking place right across the NHS over the last year. In the context of all of those impacts on the NHS, there's been, I suppose, a review of making sure that we have the right level of resilience in place, and that's led to this rebasing of the annual assurance process for the function. So this means that for the ICB and in fact for other organisations across the region and more widely, what this paper shows is a lower level of compliance than we were showing last year. That doesn't mean there's been any underlying reduction in our ability to respond to incidents and disruptions. What it means is it's highlighted a number of areas for further work and development. Many of those are relatively minor, and that those are set out in the action plan in in the paper, but there are some priorities that we've acknowledged that we do need to do some material work on, and they include the development of work on making sure we've got the right training in place for all people who might be involved in incident response, but also in the collaborative work we do with other systems on planning for future pandemics, for outbreaks, and for mass casualty situations. So we're just prioritising those as areas for further development. So I just wanted to make sure colleagues understood the context for that change in the process around EPRR assurance. So thank you.
That's great, and that update is noted. That's really helpful. I know, Brendan, would you come in just talking from the acute provider collaborative perspective, and then Beck, if you want to come in.
Anthony's very ably described it, but winter, there isn't that seasonal variation any longer. I think to the conversations we've been having, it's been all year long. We'd normally be having a conversation about what learning have we gained, but actually we've been in it. I do think our relationships have got us to a place where we've performed well compared to others, and we should take note of that. And I think our combined chief operating officers across all sectors have done a great job, and I would call out Claire Smith at Leeds and Julia Nixon in Airedale for some of the work they've done around the emergency care standard. And I think to Anthony's description around the EPRR preparedness, I would just say to anybody watching this, please be assured we are prepared. To Anthony's point, this is about new standards. West Yorkshire will one of only a handful of systems who put themselves forward to test this out, which I do agree is the right thing to do. There is further work to test out around some of our documentation and our training processes, but please be assured organisations are prepared for business continuity or in the event of mass casualties, as Anthony's described.
Thank you, that's very helpful. Becky, did you want to come in, and then I need to conclude our meeting?
Just a brief one, which is on 243 of 5.2, the letter from NHS England. Is there anything I can't work out what's not a priority from that? Sorry, so could somebody tell me what we're not prioritising now, because I don't get it.
Anthony, maybe in 30 seconds, and then maybe that's a follow-up conversation with Becky as Quality Chair. Okay, I'd suggest that that's a briefing for Becky as Quality Committee Chair for the ICB, as well as something to follow up on. Okay. Colleagues, thank you so much for your contributions to the board meeting today. You'll note that we have AAA reports in section 12. They're from across all 5 of our places and all our ICB committees that work across West Yorkshire level. So you've got all the information there, and then there's also a pack of minutes as well. And as you know, our place committees meet in public as well as this West Yorkshire group as well. I wanted to invite AC, if you can do it in 30 seconds, AC, that helps us time-wise, just talk about the Transformation Committee, which is a committee we talked about, particularly in May, that would look to refresh itself and develop further.
Thanks, Kathy. And we have touched upon throughout the day on various sort of moving parts of transformation through the primary care as an example sort of area to look at, where we are trying to bring people strategy, looking at digital sort of innovations and looking at our operational plans, combining it with what that means for the medium-term financial plan. So I think what we are trying to do is re-architect the Transformation Committee to look at our commissioning policies, standardizing that approach, but also looking at these various moving parts of the organization, the system, and looking at how we empower places. So that's why I was interested in the mapping exercise, and we can bring some of those back to the Transformation Committee and look at that and be assured that the coordination is happening as it's intended, linked to the plan, and then we are linking the financial, medium-term financial plan with the dashboard, effectively performance, which is sort of meaningfully delivering the objectives. So I think that's the work that we'll be doing over the next quarter.
That's great, and that complements what Rob's just been talking through as well, that we need to do before the end of the financial year. Okay. Colleagues, thank you so much for your contributions. I just wanted to go back on item 6. I think there's something to take that appendix on those board roles and remits. Brendan, there's a point you've made there earlier, just checking that we've got communications with all those different forums so they're aware of the roles and the purpose of people connecting in different ways. And that we don't have any other business to note. So it's to say that our next meeting will be on Tuesday the 16th of January in Wakefield. If anyone would like to submit a question in advance in relation to that board agenda that day, that would be the day before on the 15th of January. And in between that, we have some board development sessions and also some visits taking place as well to continue to be engaged across our health and care partnership. Colleagues, thank you very much for your contributions today. I hope you found that, particularly the primary care discussion, really helpful. Thank you to everyone around the table for what you're doing at this time. It's greatly appreciated. Thank you for people who've stayed with us all afternoon, either here in person in Leeds or watching online. And all the documents relating to today's meeting are online, and we'll add some extras as well. There's a few people around the table who have suggested some additional information, which we'll add as well. So thank you very much for joining us for our November board meeting.